Sorry that we actually crashed during the middle just now. So we just continue the part 2. So just to continue our patient just now. So the patient have flail anterior mitral valve leaflet with jet that is directed posteriorly. And the patient also have secondary pulmonary hypertension. So you can see that the TR, the jet is dense and also almost triangular. The patient also have secondary pulmonary regurgitation. So this patient have EROA of 0.69 centimeters squared and regurgitant volume of 69 mils. So both are severe. So this is primary flail anterior mitral valve leaflet, severe MR. The patient also has severe secondary tricuspid regurgitation. So this is a likely fibroelastin deficiency. So repair or replace, what about the tricuspid valve? So always remember to repair a repairable primary mitral regurgitation. And for the tricuspid valve, we also have to repair because there is a concomitant severe secondary tricuspid regurgitation. So this is our 5th case here. So if you look at our 2D echocardiogram, this is a parasternal long axis view here, and you look at the leaflet, there is no obvious flail or prolapse of the leaflet. Look at the left ventricle ejection fraction is normal, and there is no regional wall motion abnormalities. However, there is a mitral regurgitation here that is posteriorly directed. However, in this case, let me show you that you can see that the anterior leaflet actually go and touch the septum during systole. So this is actually systolic anterior motion of the mitral valve that cause posteriorly directed mitral regurgitation. So just remember that not all mitral regurgitation is because of primary or secondary. There is also a rare situation that you have mitral regurgitation because of SAM. In this situation, usually what you need to do is just a septal myectomy to reduce the contact between the anterior mitral valve leaflet and interventricular septum. So this is a 56-year-old man with atypical chest pain and history of hypertension. Repair or replace, none of those, because this patient have systolic anterior motion of the mitral valve, and that's the reason the patient having mitral regurgitation. Okay, this is a nice SAM there. So this patient mitral regurgitation is due to systolic anterior motion of the mitral valve. The SAM is due to multiple factors, abnormal vortices formation due to the thickened septum, also because of apically displaced papillary muscle. And you also should know that in patients with hypertrophic cardiomyopathy, they have abnormally elongated mitral valve leaflet. On average, their anterior mitral valve leaflet length is 25 millimeter compared to 21 millimeter normal. And their posterior mitral valve leaflet is 14 millimeter compared to 10 millimeter normal. Even though traditionally in SAM we think of the MR jet as posteriorly directed, in rare occasion it still can be central or even anteriorly directed. So this is our case number 6. Okay, so this is actually an interesting case. Okay, if you look at this case here, you can see that the echo looks good. All right, you look at the leaflet there, you can see that maybe there is posterior mitral valve leaflet, either prolapse or flail. Now the left ventricle looks normal and the ejection fraction looks normal, so you're not worried about that. However, if you look at the jet is directed anteriorly. Okay, this again push you towards posterior flail because the jet is directed opposite to the posterior mitral valve, opposite to the anterior mitral valve flail. However, if you look at the jet does not look very impressive. The jet seems like it's crowding the mitral annulus there, and you cannot see the tail of the mitral regurgitation. So whenever you cannot see the tail of mitral regurgitation, always think about severe mitral regurgitation and better to do transesophageal echocardiogram for this patient to ascertain what is the severity of the mitral regurgitation. So that is the crowding of the mitral valve. So what is the mechanism of the MR and what is the severity? So crowding of the mitral regurgitation. So I proceed to do transesophageal echocardiogram. Now finally you can see that this is flail of the posterior mitral valve leaflet here, and you can see the jet is very eccentric. The jet is severe but eccentric. Therefore, in this situation, transthoracic echo actually can mislead us. So transthoracic echo show not severe, but it's actually very severe mitral regurgitation secondary to posterior mitral valve leaflet flail. You see again, this is the picture of the posterior mitral valve leaflet that is flailing, all right? And you can see this is the vena contracta here, and the vena contracta here, the size is about 8.4 millimeter, again showing that it's severe. And nicest one, you look at the 3D unfast view, you can see a P2 segment, and you can see a flail and ruptured chordae there, right? So this is a severe mitral regurgitation secondary to posterior mitral leaflet flail. The severity is not really appreciated on transthoracic echo. Now remember the E velocity more than 1.2 meter per second, that can become a clue for severe primary mitral regurgitation. I just wanted to show you an example of a view after mitral valve repair. So this is the same patient as before. This is a long axis view, mid-esophageal in transesophageal echocardiogram. This two thing here is ring of the mitral valve repair, and you can see that there is no more mitral regurgitation. So this is a perfect mitral valve repair for primary mitral regurgitation. So this is our 7th case here. You can see in this case, there is no obvious mitral valve prolapse or flail. Okay, the mitral valve appear thickened and calcified. However, the more glaring abnormalities, look at the left ventricle. It's not a very good window, but the left ventricle appear dilated and the ejection fraction is down. So there is a little bit probably moderate posteriorly directed MRZ. So you want to know what is the etiology. So let's go and look at another window. Look at another window. This is an apical 4-chamber view. You can see that the MR is definitely at least moderate, already going into severe, and you can see the LV is dilated. The ejection fraction is poor. It is less than 25%. Okay, so ladies and gentlemen, I have shown you atriofunctional MR. I have shown you ischemic mitral regurgitation. I have shown you example of flail mitral valve leaflet and example of myxomatous degeneration. So this is another example of someone with functional MR, dilated cardiomyopathy. Okay, this is a combination of type 3B and type 1 of Carpentier classification. And you can see this in an apical 2-chamber view. That's the left atrial appendage there. The LV is dilated. Same patient. So this is a functional MR secondary to LV dilatation. You have displacement of both papillary muscle upwards, causing posteriorly directed MR jet. And of course, in this patient, the annular is also dilated. EF is only 27%. So in functional MR, dilated cardiomyopathy can still be due to coronary artery disease, but the disease process is already too far apart. So you no longer put that inside the category of ischemic mitral regurgitation. In this case, the progression is advanced and global. You can have global hypokinesia and dilatation causing one apical displacement of papillary muscle causing tethering and tenting. However, in this situation, you also have contribution more than ischemic MR in terms of annular dilatation. The jet can either be directed centrally if more annular dilatation, or posteriorly is more tethering and tenting. The ejection fraction will be depressed, less than 35%. And this may be the example of proportionate mitral regurgitation that we talk about that might not be benefit from mitral clip. So this is our 8th case. Now we have been talking about mitral regurgitation. I just wanted to show you the whole spectrum of mitral valve disease. So this is a mid-esophageal TEE view. You can see that this is mitral valve leaflet. However, something that you can see here, both leaflet here are attached to only a single papillary muscle. All right, attached to a single papillary muscle. And you look at the color Doppler, you can see that there is flow conversion from left atrium to left ventricle. So this is actually someone with mitral stenosis. The mean gradient is 12 millimeter mercury across the mitral valve. And what happened to this patient? So this is actually a patient with a parachute mitral valve. Parachute mitral valve is a congenital heart disease in which both leaflet is attached only a single papillary muscle. You can also have doming of the anterior mitral valve leaflet. So in this situation, the only way that you can correct it is by doing valve replacement. And this patient have a nice bileaflet metallic valve replacement. You can see here, this is post-op of the patient. So this is our 9th case. So again, as we can see here, this is actually the same case as before. You can see that the leaflet is thickened. You can see that the anterior leaflet is somewhat prolapsing. And you can see that the jet is directed posteriorly, but the jet is very brief. So this is an example of someone with mitral valve prolapse, anterior mitral valve prolapse more with posteriorly directed MR jet. Now, however, this is again just showing you the zoom view, okay, showing you again the patient have very big prolapse of A2 and A3 segment, and maybe a little bit prolapse of the P3 segment here, and you can see the annulus is dilated. However, I just wanted to show you this patient also have secondary tricuspid regurgitation and also possible myxomatous tricuspid valve disease. Okay, this is our 10 case. Okay, what about this case? So if you look at this case, again, you can see this patient have mitral regurgitation. And can you tell me what is the mechanism of the mitral regurgitation? Now, looking at this patient, the anterior and posterior mitral valve leaflet looks okay. Look at the left ventricle, the ejection fraction is normal, and there is also posteriorly directed MR jet. However, there seems to be like something just there going down here. So this is not quite sure what is the mechanism of MR. Now, if you are not sure what is the mechanism of MR, don't say the mechanism, try to find out more. So in this patient, actually, we do a transesophageal echocardiogram, and actually at the end of A2, so this is A3 segment, you can see a prolapse segment of A3, okay? So rather than telling the patient mechanism that we don't know, when we do TE, you can see that the patient have A3 prolapse causing mitral regurgitation. So already have secondary pulmonary hypertension. You can see the D shape of the left ventricle. You can also see all leaflet of the tricuspid valve. That's anterior, septal, and posterior leaflet. Now, when we do a 3D view, you can see that A1, A2, and you can see an A3 prolapse there in 3D view. So this is someone that have A3 prolapse that is not clear on transthoracic echocardiogram. Patient also have secondary TR and clear all three tricuspid leaflet in short axis view. This is our 11th case, all right? Now, we already talked about parachute mitral valve. So this is another example of mitral stenosis, but this is rather, if you look at the leaflet here, the leaflet is very calcified, especially at the annulus. So whenever you see the leaflet that is calcified in the annulus, always think about mitral annular calcification. Most commonly, this causes mitral stenosis, but also in a rare time, it also can cause mitral regurgitation. You can see a flow convergence across from the left atrium to the left ventricle here. Right, so this is apical four-chamber view, left atrium, right atrium, left ventricle, right ventricle. Again, you can hear a calcification here. You can see that the mean gradient across the mitral valve is 7. So this patient have moderate to severe mitral stenosis secondary to mitral annular calcification. So what is mitral annular calcification? Mitral annular calcification is a process because of aging in which there are calcification of mitral valve annulus and also formation of a new calcified material, just like a bone formation. It happens normally in the annulus and start at the posterior annulus of the mitral valve leaflet. It can go circumferentially to all the mitral annulus. It also can spread to mitral valve annulus base all the way to the leaflet tips, but it from the base to the tips. It is most commonly at the P2, P3 region of the mitral valve where the strain is at its maximum. Rarely can cause severe mitral stenosis, however, can occur in association with mitral regurgitation. Healthy calcification can make mitral valve repair difficult, however, it can still be done. It is commoner in the elderly and those with chronic kidney disease, pathophysiological similar to bone formation. Sometimes the MAC itself can cause MR as it goes underneath the mitral valve at the LV site, causing chordae rupture. Sometimes the MAC itself can be below the leaflet, but the leaflet itself might not be affected. In this case, mitral valve repair can be done more easily. What happens sometimes is that the MAC can be liquefied and cause caseous necrosis. This can actually mimic vegetation and can mimic mobile clot, so don't be fooled. So this can be left alone unless it causes recurrent stroke. For primary MR, I just wanted to stress you again, finally, always repair unless in the setting of acute MI with ruptured papillary muscle due to tissue friability, Heavy calcification, for example, someone with severe mitral valve prolapse with severe posterior mitral annular calcification, rheumatic mitral valve again with heavy calcification, and infective endocarditis usually we don't repair because of the bileaflet destruction. If you have Barlow's disease with severe calcification, also normally it's very difficult to repair. This is just a setting where we don't repair a primary mitral regurgitation. I just wanted to finish with a few bonus case, right? So this is someone with parachute mitral valve, so that's anterior mitral valve leaflet, posterior valve leaflet, attached to only a single papillary muscle. What I do, I mean my mitral arcade. So mitral arcade is when the leaflet is attached to a very short chordae tendineae, or there is no chordae tendineae alone. So as you can see, this patient, posterior mitral valve leaflet, there is no chordae or very little chordae attached to papillary muscle. Okay, that is a mitral arcade. So this is the same patient with mitral arcade and also mitral stenosis. That is mitral arcade. That's another example here. So that's quite another different patient with congenital stenosis, double orifice mitral valve leaflet. So the mitral valve leaflet have double orifice. Okay, this is congenital disease. So this double orifice is actually give idea to Italian surgeon called Ottavio Alfieri to do mitral clip procedure. So when he do his first operation in a patient with atrial septal defect and double orifice mitral valve leaflet incidentally. His second case is someone with mitral valve prolapse. So he was thinking, why don't he mimic the thing that he see in the first operation where the woman have naturally occurring double orifice mitral valve leaflet. So that is where the mitral clip come about. So this is someone with double orifice mitral valve. The mitral clip procedure takes its inspiration from the Alfieri procedure with end-to-end stitch. The surgical procedure was pioneered by Ottavio Alfieri. His first operation was someone with ASD and parachute mitral valve. He then take what he see and try to recreate it in his next patient who indeed have mitral valve prolapse. I just wanted to remind you again a simple management to mitral regurgitation. All right, so this is what I showed before. Okay, just to summarize, remember we differentiate MR between leaflet problem and leaflet problem we call primary. The most common is prolapse and flail. In prolapse and flail, we repair unless we cannot repair. Okay, in rheumatic and degenerative, usually we can either repair or more commonly replace the valve. In primary, we are aggressive. We intervene when MR is severe. We intervene when the MR is severe and the patient is symptomatic. We intervene when the LV start decompensate. In ischemic and functional MR, the problem with the left ventricle, so we try to correct the left ventricle first. Unless we have other concomitant operation in which if we have severe MR, we also repair the mitral regurgitation. In all these conditions, if the patient is not fit for surgery, you can consider mitral clip. So this is my take-home message. First step is to determine what is the etiology of MR. Is it a leaflet primary problem? Is it ventricle, either functional or ischemic? Or is this atrial functional MR? Assess the severity. Use 2D appearance, color appearance, semi-quantitative, and lastly, calculate the EROA and regurgitant volume. The number to remember is vena contracta 7 mm, EROA 0.4 centimeter squared, regurgitant volume 60 mils, EF 60%, and systolic dimension of 4 centimeter. Ask whether the patient is symptomatic. Remember, if the patient is severe and they are symptomatic, they get ticket to go to operating theater in primary MR. Then a range intervention is needed. So thank you everyone for your kind patience.